Hi guys, this is Tony with GlomCon Pace, but just want to let you guys know that every second Sunday of every month, there's going to be a Zoom Pace meeting. There's going to be a nephrologist on there answering questions, wonderful things. So I highly encourage you to join. And right now we have Dr. Singh answering questions for you. So if you want to join the GlomCon, all you got to do, or the PACE meetings, all you got to do is go to glomcon.org, scroll down to patient portal, click on the link. It'll tell you right there when's the next meeting, the time, click on join, and you can join that way. If you want to submit questions anonymously, you can. There is also a link on that. Just click on submit questions, and there you go. It'll be answered. So hope to see you there. So we have some questions. We have Dr. Singh on board, and she's going to answer some questions that some of you guys have.
Yeah, good evening, everybody. I'm Dr. Tripti Singh. I'm a board certified nephrologist who works at University of Wisconsin-Madison, and I have a special interest in patients with glomerular diseases, as well as one of my interests is in patient education. And so I'm a part of GlomCon PACE, which is something new that we are starting to improve to help patients learn more about their diseases. So just a little bit of disclaimer before we start about Q&As. The space is a patient-caregiver engagement. Only patients and caregivers are allowed to participate in these meetings that we have at GlomCon PACE. This event is not to obtain, solicit, or share medical advice, but serve only for general education purposes. This event does not and cannot relate to care provided by the kidney doctors or your own nephrologist. For individual health or kidney disease related questions, please speak with your own nephrologist. The goal of these sessions is just to help you understand your disease a little bit better for you yourself or your loved one who might have a kidney disease or a glomerular disease. So now that we are discussed all the disclaimers, we'll start with our first questions in the live stream.
Okay, so the first question was, I was told by my doctor that I have protein in my urine and I need to see a kidney doctor. What does protein in the urine mean?
Yeah, that's a great question, Tony. So protein in the urine means, so normally in a urine that's made by our kidneys, there should be no protein or no blood in the urine. So kidneys are a filter and they should get rid of the toxins, but keep like the good things that our body needs, like protein and blood in our blood, and not lose them in the urine. So if there is any protein present in the urine, that is a sign that there's something wrong in the kidneys or there's some damage to the kidneys. Most of the time, when there's protein in the urine, the damage is in that particular part of the kidney, which is called as a glomerulus, where all the filtration initially happens. And you might have a disease which come into what we call as glomerular kidney disease. Like I said, any protein in the urine is marker of the disease, so it's an early marker of kidney disease for the most time. For the most part, your kidney might be filtering the toxins okay if you have protein in the urine, but this is just very early marker, and sometimes a clue towards diagnosing the kidney disease that you might have. There are a couple of ways to test the proteins in the urine. Your doctor might check a dipstick, which is just dipping, and that's a screening test, which sometimes is done to see if there is protein present or not. And if there is present, then it is always recommended to actually quantify, meaning actually measure how much of protein is in the urine. There are two ways of doing that. One is by doing a sample of the urine, preferably the morning sample, but can be done at the any time of the sample, and you measure the urine protein and urine creatinine, and you divide the two, and that's called as a urine protein creatinine ratio. And that ratio is kind of equivalent to the 24-hour urine, which is the second way of measuring that you collect all the urine in the 24 hours that you pee in a container, in a jug, and then you give it to the lab, and then they actually measure the amount of protein in the urine. So those are the two ways that you can check it of having protein in the urine.
So another question that came up was, is it important to do the first morning urine for accurate results?
Yeah, this is a great question. And sometimes it's not easy to do the first morning urine, although it is the most accurate way of getting a 24-hour or getting a urine, which is equivalent to 24-hour urine by a single urine specimen is morning urine. If you have huge amounts of protein in the urine, which can happen in some glomerular disease, then doing an afternoon urine versus a morning urine might not be so much different. But if it's a small amounts of protein, there's always a little bit difference in the morning urine because the morning urine tends to have a little bit more protein in the urine. And so that's again a sensitive marker. So it just depends on how much protein is in there. If somebody has, let's say, like normally there should be 0. And if somebody has 10 grams, which is huge amounts of protein in the urine, then taking a morning versus the afternoon is not much different. In that matter, I tell patients it's not worthwhile for you to take a cup in the morning, cup to home, and then get your first sample and bring it to the lab within an hour, because it does take some planning to happen. So it just depends on where in the disease you are.
Right. And another Facebook question was, at what point would a nephrologist decide to do a 24-hour urine collection versus just a first morning urine?
Yeah, and I think a lot of it just depends on your nephrologist too, and there's a little bit of difference in practice as well. Sometimes I would say it's if there is a lot of discrepancy in your clinical presentation versus the urine testing, that's one of the times when I would recommend doing it. Sometimes in the beginning of the disease, when you really want to confirm how much of protein is in the urine, that would be one of the other times you're doing it. Sometimes if some of the tests are improving, but your protein is not improving, so if I feel like there's some discrepancy, then I would do it. But for the other times, majority of the times, I would say about 90% of the times, a morning urine specimen is as good as enough as 24-hour urine. So there are a few instances that I still do that, but I do agree it's very cumbersome and it's not easy to do. And keeping a urine jug in the refrigerator, which no one wants to do, and not be able to travel or go out of the house any day is not easy.
Right.
So,
right.
Yeah.
Okay. Another Facebook question. If using the home test strips and then someone tests 1+ or greater, how many days do they test before calling the doctor?
Yeah, that's a very good question as well. And I do sometimes tell some of my patients to do home testing as well when they know they're going to have a relapse of one of their diseases, something like minimal change disease or FSGS, different types of kidney diseases that are. I would not wait for more than 2 days if you have 1+ positive, 2 to maximum 3 days, because earlier you figure out, the better it is. It also helps you. Sometimes I just tell my patients, it also helps ease the mental anxiety that you get by getting, if it's a negative test, you don't have a relapse, and it really helps. So it's as simple as giving a lab sample. Sometimes I just put in the order is active, and my patients just go and give a sample, just because I think people get to know about their body and they know when they're having a relapse. But I would not wait for more than 3 days. I would say if you have a urine dipstick turn from negative to positive, for a urine test to be done in the lab.
I see. Okay. So what's considered abnormal protein in the urine?
Another great question. I know we talked about any protein in the urine is abnormal, but there are different types of proteins sometimes that can be checked. So there are 2 different types of proteins that are checked in the urine in the lab. If you send your urine to the lab, one is what we call as the total protein and comes as urine protein. The other one is sometimes your doctor might check called as albumin in the urine or microalbumin. So those are 2 different types of protein. Protein includes albumin plus some other proteins which are called as tubular proteins, and they can be some amount of tubular proteins which are normal, and that's up to 2.2 grams in 24 hours, or 200 milligrams in 24 hours of protein is normal. But having any albumin in the urine is abnormal. So you just really have to figure out which protein your doctor is testing in the urine. If it's albumin, then any is abnormal. If there's protein, then up to 200 milligrams or 0.2 grams is normal. And anything above that would be abnormal.
So abnormal meaning what's considered, that was another Facebook question, what's considered nephrotic?
Great question. So then when you're looking at protein in the urine, then anything, like we said, above 0.2 is abnormal. And then you could have different, how much above 2. So anything of 0.2 grams per gram, that's the ratio of protein to creatinine ratio, which is equivalent to 0.2 grams of protein in a day. So whenever I say 0.2, that means 0.2 grams of protein in a day, or more than 0.2 grams of protein in a day, or that ratio becomes 0.2. So anything from 0.2 to 3.5 grams in a day is what we call as subnephrotic, or below nephrotic syndrome. Any protein in the urine which is above 3.5 grams a day is called as a nephrotic range proteinuria, or having huge amounts of protein in the urine, because a normal protein in the blood is normal is between 3.5 to 4. So if you lose all of that protein in the urine in one day, that becomes huge amounts, and that's what we call as nephrotic range proteinuria. Along with that amount of protein in the urine, if you have that starts affecting your body per se, that becomes nephrotic syndrome. And when I say affecting your body, means it causes swelling in the legs, which is what we call as edema. It can cause swelling in your belly because of the fluid retention. It can make your cholesterol levels go high. So your doctor will check your cholesterol level if they go high, if your protein levels in the blood is low. And so that means it starts affecting your body. That's what becomes a nephrotic syndrome per se.
Right. So one of the questions is, what can help decrease the protein in the urine?
And again, a great question. So a lot of the ways that we can decrease the protein in the urine depends on what's causing the protein in the urine, right? Because it's one of the marker of the kidney disease, and there could be a lot of kidney diseases which can cause protein in the urine. From one of the most common causes of protein in the urine is diabetes, which is one of the most common causes of kidney disease as well, which also causes protein in the urine. And so for your kidney doctor to figure out what's causing that, most of the time they would consider a kidney biopsy to figure out what is the cause of the kidney disease or what's causing the spilling of that protein in the urine. In some instances, they might not do a kidney biopsy. The only time when they might not do, possibly or not considered, if you've had a long-standing diabetes and they think that it is because of the diabetes that you're spilling the protein in the urine. In all other instances, I would presume that your kidney doctor will, or your primary care doctor should refer you to a kidney doctor, and the kidney doctor will need a kidney biopsy to diagnose the disease. And depending on what disease they find on the biopsy, they would consider different therapies for it. This is about specific therapies. Again, like I said, whatever is causing protein in the urine, there are certain things that you can do and certain medications that the doctor will give that decrease the protein in the urine. And these things are irrespective of what the disease it would be it diabetes, be it FSGS, be it minimal change disease, be it lupus, be it membranous. So there's different types of diseases that could cause protein in the urine. And these certain common things that you can do, the first one is low salt diet. So decreasing the salt in the diet, and how much is about 2,000 milligrams of salt or sodium is what staying below that helps decrease protein in the urine. The second one is, I'm going to go in the major ones. The second one is decreasing your blood pressure if you have higher blood pressure. So you're having your blood pressure below 125/75 helps decrease the protein in the urine. And one of the most common medications that your doctor might put you on when you have protein in the urine to help decrease the blood pressure or just decrease the protein in the urine is a group of medications that we call ACE inhibitors or ARBs. The most common medication names are lisinopril or losartan in that group. They help, both these class of medications help decrease the blood pressure as well as help decrease the protein in the urine. And then there's a newer class of medications, what we call as SGLT2 inhibitors, the most common names being Farxiga or Jardiance. Those two medications also help decrease the protein in the urine. So this is talking about medications, the low salt diet. The third thing would be if you are overweight or obese, decreasing weight helps decrease protein in the urine. If you smoke, quitting smoking helps decrease protein in the urine. And doing moderate physical exercise and being physically active also has been shown to decrease protein in the urine as well. So these are a combination of things which are irrespective of what the disease is, helps decrease that protein in the urine.
So we have some more questions from Facebook, but this is kind of geared towards a little bit towards treatments. So one of the questions was, is prednisone still the initial treatment for FSGS if they're not secondary?
Yeah, great question. So a lot of time prednisone becomes the first line of therapy for all patients who, I wouldn't say all, but majority of patients who have nephrotic syndrome. And if that cause when you do the biopsy is either FSGS or minimal change, and sometimes even membranous, then leading to nephrotic syndrome, yes, then the first choice of therapy is prednisone or steroids is what we say, high dose steroids. And if they're adults, then usually a prolonged therapy for about somewhere about 16 weeks of total 4 months of high dose steroids is what is recommended by the guidelines. And one of the things I would say, I know today we are talking a little bit more broadly about kidney diseases and protein in the urine, but in our future pace, similar meetings that we have, we will focus on specific diseases. That's our goal. Like there would be one about FSGS, there would be one about minimal change disease, there would be one about lupus nephritis, and where we go into more details about treatment options, what is recommended by the guidelines, and going into more details about nuances about treatment of specific diseases as well. So that's just the plug-in for our future meetings.
Right. Gives an opportunity for people to join, right? Again, we got proteinuria. There's going to be clinical trials. There's going to be, I think, already the treatment options. There's going to be a variety of topics. So that's kind of encouraging for people to join. I think those are all the questions that we have for now.
Perfect. Okay. Sounds good.